Okay. So we'll go back to now discussing the pathophysiology of the various conditions following the various organ systems. So we'll discuss about pathophysiology of respiratory disorders, diseases. So we'll just pick a few. We are not going to discuss each and every condition under those systems. So we start with asthma, which is a respiratory or airway disease. So talk about asthma. We start from the definition of the condition. So usually that's how we want to discuss this. Even when I'll give out the work to be discussed in groups, you start by the definition of the condition, its causative risk factors, the pathophysiology. Then we'll go to now the signs and symptoms. Yes? Are we following?
Yeah.
Okay, thank you.
Yeah, we're following.
Yeah, so when talk about asthma, that's a chronic inflammatory disease of the airways. It affects the airways, usually by causing airway obstruction. And you talk about reversible airway obstruction. It causes or characterized by airway hyperresponsiveness and also recurring symptoms like the wheezing, the coughing, the chest tightness, and shortness of breath. So that is basically a simple definition of asthma and a chronic inflammatory disease of the airways. And usually, asthma is a reversible disease within the early stages. So you can see here we have a normal airway with relaxed, smooth muscles. And we can see now an airway that has been inflamed, it has been thickened, and also the smooth muscles have tightened. And that means now airflow is affected because now air is trapped in the alveoli because of the tightened smooth muscles and also that inflamed and thickened airway lining. Usually, it's characterized by wheezing, by coughing, shortness of breath, and chest tightness or pain. And we want to look at, we're coming back to see how do these clinical manifestation come about. That's what we'll be talking about, pathophysiology. Some of the risk factors associated with asthma, we have the endogenous and the exogenous factors. Endogenous, that's the internal factors, the exogenous, external stimuli factors. We have, just a minute. Yeah, so the endogenous factors, the genetic predisposition, sometimes people genetically predisposed families of asthma. We have atopy. We talk about atopy still, it's a genetic predisposition, but now this one leads to development of allergic conditions, which are mostly strongly linked to asthma. And we'll talk about, if we talk about the types of asthma, we know we'll talk about atopic asthma. Airway hyperresponsiveness as another cause, gender, the ethnicity, the obesity, viral infections. Exogenous factors, both indoor and outdoor allergens, occupational sensitizers or occupational exposures, passive smoking, respiratory infections are some of those factors of asthma. Risk factors, the allergens, viral infections like the upper respiratory tract viruses, like the rhinoviruses, pharmacological agents like drugs like the beta blockers, the angiotensin converting enzyme inhibitors, the aspirin, exercise, where we talk about the exercise induced asthma, which again can exacerbate the asthma. Physical factors cold air, hyperventilation can trigger that. Some foods, some air pollutants, some irritants, okay, some occupational factors, some hormonal factors. All these are factors that can trigger asthma. We have various types of asthma. We have atopic asthma, which is usually an IgE or immunoglobulin E mediated hypersensitivity or an allergic sensitization asthma. Usually, one again will have positive history of asthma in the family. So atopic asthma is like allergic asthma, or there's allergen exposure. Then an atopic asthma, there is no allergen sensitization, no history of asthma in the family, and usually a negative skin test to allergies that can cause asthma. We have the drug-induced asthma, like those who are sensitive to some types of drugs, like the aspirins, the non-steroidal anti-inflammatory drugs, and the rest. We have the occupational asthma. Usually, if one has been exposed to stimulants like the fumes, like the chemical dusts, the penicillin products, and such like. Exercise induced the asthma, which comes in after one has been engaged in an exercise or in an activity. Usually, we have the early phase of asthma and the late phase of asthma. Early phase peaks about 30 to 60 minutes after exposure and then gets to subside about 90 minutes later. Usually, will be characterized by bronchospasm. You know what bronchospasm is? Anybody who can know what bronchospasm is? Some of those medical terminologies that you need to start getting used to. So we talk about bronchospasm, that is constriction or narrowing of the airways. We talk about spasm, that is the narrowing the broncho. We're talking about now the airways. Basically, that is as a result of tightening of the muscles around the bronchial tubes. It's also characterized by mucus secretion, edema formation, increased amounts of sputum, and all these are going to cause um, tightening of the airways. So patients will experience wheezing, they'll experience cough, they'll experience chest tightness, and also dyspnea. Why are they experiencing this? Because now there's increased mucus secretion, which has accumulated in the linings or in the bronchial tubes, and that means that now breathing becomes a difficulty. So that's why they'll produce the wheezing sound. Coughing, because now they are trying to expectorate that excess secretion along the airway tubes. Dyspnea, difficulties in breathing, because of course the increased secretion that has accumulated along the airways. So that's how you get to determine the signs and symptoms. The late phase, which is characterized by inflammation, where now the various histamines, the various mediators now cause airway reactivity. And if there is airway activity, hyperactivity, there will be hyperresponsiveness. And with the hyperresponsiveness, there will be, trapping of the air in the alveoli. There will be hyperinflation in the lungs. And usually, if this is not managed early enough, it can easily lead now to irreversible lung damage. So this is still an illustration of asthma, both the early phase and the late phases in response to asthma. So one has been exposed to the triggers, be it infections, be it allergens, be it exercise, be it irritants. There will be, of course, because of the exposure to that, like the allergens, the immunoglobulin E mast cell mediated response will be activated. Sorry. which will help to release the various mediators from the mast cells, the eosinophils, the macrophages, the lymphocytes, because that's an inflammatory response. So during the early phase, there'll be smooth muscle constriction, there'll be mucus secretion, vascular leakage, mucosal edema. During the late phase, there'll be, of course, infiltration with the eosinophils, the neutrophils, which will cause bronchial hyperactivity. And all that again will lead now, be it in the early phase or the late phase, will lead to obstruction of both the large and small airways, will lead to trapping of air in the alveoli, uh, can now lead to respiratory acidosis because of the trapped air. Gaseous exchange is not taking place as intended. That can lead now to hypoxemia, where now blood will be concentrated with CO2, and that can now affect the tissues and cells of the body. So the pathophysiology of asthma. Are we following, guys?
Yes.
Thank you. So pathophysiology of asthma will now follow those four components: airway inflammation, airflow obstruction, bronchial hyperresponsiveness, and then airway remodeling after healing starts to take place. When we talk about airway inflammation, the triggering agents, remember, have come in. The allergens, the infections, the irritants, the exercise. We've just talked about them. When one has been exposed to any of those triggering agents, they are going to initiate an inflammatory response. The inflammatory response will involve, of course, various cells, which will include the mast cells, the eosinophils, the lymphocytes, which are going to release now those chemical mediators, the cytokines, the histamines, prostaglandins. And with the release of that, they will lead now to increased mucus production. There will be vascular congestion, because now vascular congestion, because this is an inflammatory response, so more of blood is trying to now get into those areas because they want to respond to that inflammatory reaction. They'll also lead now to edema. That's what happens during airway inflammation, the inflammatory response. That's the first thing. After that, there'll be bronchial hyperresponsiveness. Actually, it should follow bronchial hyperresponsiveness, then obstruction will fall after that. Now, with bronchial hyperresponsiveness, now the inflamed airways, because here there has been an inflammatory response, the inflamed airways now will be sensitive to various stimuli. Even with any minor exaggeration or any minor trigger, it will lead now to accelerated bronchoconstriction. Because now, with the airway inflammation, there will be bronchoconstriction. So any slight, again, trigger now, it will lead out to accelerated bronchoconstriction in, trying to respond to that. With now accelerated bronchoconstriction that comes about as a result of bronchial hyperresponsiveness, there will be airflow obstruction. The airflow obstruction is because of now smooth muscle constriction, because of the bronchospasm. You saw that there in the schematic drawing I showed you earlier on. There will be smooth muscle constriction, mucosal edema, because of now of the accelerated bronchoconstriction and the hyperresponsiveness. Then there will be thickened mucus secretions. The thickened mucus secretions will reduce the airway diameter. And if there is reduction in the airway diameter, there will be increased resistance in terms of airflow. Because now mucus secretion is taking place, But of course, one thing here is there is hyperproduction of the mucus. So it's being produced in large quantities than normal. That's one. Secondly, this mucus that's being produced in large quantities is thickened because of this inflammatory response. So that means that now it's going to reduce the diameter of the airway, and that's going to cause now increased resistance to airflow. And you know that means now patient will start presenting with the difficulties in breathing, the wheezing sound, the coughing. You will be trying to open up the the airways to increase airflow. Then lastly, there will be airway remodeling. Airway remodeling usually comes in now in poorly controlled asthma or in chronic asthma, where now there'll be fibrosis, which can lead now to over time, can lead now to irreversible airflow limitation, and that can easily now lead to over time lung failure. So the clinical consequences of these four processes, most especially the first three, the clinical consequences is there'll be wheezing, there'll be coughing, there'll be shortness of breath, and there'll be chest tightness, more especially at night, chest tightness, more especially at night and early in the morning, as the cardinal signs of chronic inflammation. So you can see here, airway inflammation because of increased hyperresponsiveness, which leads to bronchospasm, and that's going to present with wheezing, will present with shortness of breath and coughing. Of course, the inflammatory response, the chemical mediators for inflammation will also cause that. The cells involved, of course, are the cells we've just talked about in inflammation, the inflammatory response that we've just talked about. So I can't repeat the cells involved. The effects of inflammation, we know that I don't talk about that. There will be airflow obstruction because of inflammation. Of course, there will be obstruction, including now the bronchoconstriction that comes in and narrows the airways, the edema in the airways, the mucus that is now being oversecreted will all cause bronchoconstriction, and that's going to affect airflow within the airways. So that means that now there'll be increased resistance to airflow, decreased expiratory flow rates because now they are struggling to expirate. Then hyperresponsiveness, which I just talked about, which will still alter the airflow within the airway tubes. Remodeling usually comes in when the asthma is persistent and it's chronic and it is left untreated. So with remodeling now, that will be irreversible narrowing of the lumen, airway lumen. There'll be decline in the lung function and fibrosis, and eventually can lead now to permanent lung damage.